Hi everyone, it's 12:30. We'll go ahead and get started. Good afternoon and thank you all for joining the UNC Rex Heart and Vascular Grand Rounds and the UNC Health System Network Development and Physician Relations virtual COVID CME series. My name is Lisa Moore and I'll be your host for today's session. We intend for this WebEx to be highly informational, and to that end, we ask that everyone remain muted throughout the entire presentation, except for our speakers. We are monitoring the chat feed carefully, so if you'll use the chat to everyone feature, we'll monitor your questions as they come in and answer them at the end of the presentation. It's been our experience that the audio feed is slightly improved if everyone, with the exception of the speakers, will turn off their video feed. So if you can all take a moment to make sure your video feed and also is off and that your audio is muted. To receive CME credit, you must be registered with the MyAHEC account. And this afternoon, we're going to be discussing complications of COVID-19 infection. We will be recording the session and it will be posted later on the Physician Resources page for UNC Health. However, the recorded version of the program is not eligible for CME. And before I announce today's speakers, if you please make sure that you're muted and that your video feed is off. I'd like to introduce the speakers for today's presentation. We have Dr. Shannon Carson. He's the Chief of the Division of Pulmonary Diseases and Critical Care Medicine at UNC. Dr. Nigel Key is the Director of Hemophilia and Thrombosis Center. Harold R. Roberts, Professor and Vice Chief of the Division of Hematology Oncology. And then also Jenny Flythe, Assistant Professor of Medicine and Medical Director for the Acute Dialysis Unit of UNC Hospitals. So Dr. Carson, we'll let you go ahead and get started.
Okay, thank you everyone for joining us. I know you're busy here in the middle of your day. I'm going to speak about the pulmonary complications of the COVID-19 syndrome. Next slide. I do some clinical trials and research related to ARDS, but I'm not going to be talking about any agents that's been part of our clinical trials. I'm going to primarily focus on the complication of pneumonia and the acute respiratory distress syndrome that includes hypoxemic respiratory failure and is associated with sepsis and shock in many cases, and particularly delirium. Dr. Flythe will talk about the associated acute renal failure. Dr. Key will talk about pulmonary embolus and other thrombotic complications. I will not spend a lot of time on some of the other complications, but I will note that we've had a remarkably few number of our chronic lung disease patients come in with this infection, although you would expect them to be more susceptible. I think that's because all of you have been doing a good job of warning them to keep themselves isolated and distanced, as hard as that is, but it's particularly important for them. Next slide. So I'll drag you back to medical and nursing school briefly and remind you about the physiology of ARDS. The alveoli are usually pretty clean and pristine structures, matching ventilation and perfusion through the alveolar capillary. When there's infection or other insult to the lung, you get an inflammatory response with a number of inflammatory mediators, beginning with alveolar macrophages drawing in neutrophils, which really stir things up. Then you get, after a few days, some hyaline membrane formation, which further limits oxygen exchange, and then later on fibrosis in the more severe cases. You also get some inflammation related to endothelial cell activation. Sometimes we possibly even direct infection with this particular virus, with neutrophils being recruited to the lung, getting into the interstitium, and causing more inflammation. And as Dr. Key will talk about, potentially thrombosis in these key alveolar capillaries. Next slide. So is the ARDS that we see with SARS-CoV-2, is it different than our ARDS with bacterial pneumonia or viral pneumonia? We're not sure. Some clinicians feel that the hypoxemia that we've seen with this disease is out of proportion to the abnormality that we see in lung compliance. With bacterial ARDS, often the lungs tend to be a bit stiffer, but with SARS-CoV, the hypoxemia seems to be more profound. But that's difficult to prove and to do exact matches. But we know that the inflammatory response is pretty significant, and the higher levels of inflammatory markers like IL-6 or CRP that we see, then the more likely that patients are going to require mechanical ventilation, for example. There's also the possibility of endothelial injury with thrombosis that I mentioned earlier, and we hear about a little bit later. Anecdotally, it seems that there's less associated shock with this condition than, say, with bacterial pneumonia, and that's possibly understandable. You get more circulating endotoxins with, say, gram-negative bacterial infections and less shock, although some degree of shock is not uncommon, particularly when these patients get intubated. Delirium has been a big problem in these patients, and we are very curious as to whether there are direct effects on the brain by the viral infection, or whether it's entirely a manifestation of the systemic inflammatory response, plus the significant amount of sedatives that are required to help us ventilate these patients safely. Next slide. So what do we do when we manage patients who present with viral pneumonia? Potentially the most important slide for this talk is not even here because the data have only been released today in a news release. If you check the news later today, you'll see some information about a large 6,000 patient trial out of the United Kingdom called the Recovery Trial, where it's a large pragmatic study where multiple hospitals enrolled patients into multiple interventions for COVID-19. And they stopped one trial early, and that's a trial of dexamethasone given 1 time a day in 6 milligram doses, either oral or IV. That study had about 2,700 patients in the intervention arm, and it was stopped because this study showed a significant benefit for patients who require mechanical ventilation or who require oxygen in the hospital for COVID-19. In fact, the mortality for mechanically ventilated patients was reduced by about 30%. So a number needed to treat of 8 patients for 1 life saved. Now that's a pretty remarkable outcome for patients with ARDS. There's only one other intervention, and we'll talk about a little bit later, that has that same impact on ARDS. So we haven't seen the actual data yet, although one of my colleagues has seen some of the results curves pre-publication, and he agrees that the results appear to be impressive, and we know it was a well-designed study. So my colleagues will discuss this afternoon what we're going to do with this trial. We've been avoiding steroids in these patients because steroids actually increase mortality in patients with the H1N1 influenza pneumonia. And so we translated that to avoid steroids in this case, although steroids may be beneficial in some other forms of community-acquired pneumonia. The data there are mixed. But this is a large study, well-designed, and probably is going to have a significant impact on the management of these patients. And you know, the news release just out today. Next slide.
Grab it.
Well, she's trying to get the next slide up. I was going to next talk about some antiviral therapies. There you go. We are using remdesivir here, either under the FDA's extended use agreement or extended access programs agreements. This is restricted in patients with significant renal failure or high transaminase levels. But despite that, a large number of our patients have been able to get started on remdesivir. One trial suggested benefit, and so we're waiting for further data and FDA approval. But for now, under these programs, we're providing the drug. Another drug that we're sometimes using empirically is Kaletra, an HIV medication, a combination of lopinavir and ritonavir. The data on that are mixed out of China. There are multiple clinical trials going on with that drug, or with that drug combined with an immune modulator like interferon, which could be beneficial, and we're waiting for data. We're also enrolling patients in a clinical trial here for convalescent plasma. We're not using hydrochloroquine. We had a clinical trial going on with it, or part of a clinical trial, but we had to stop trying to enroll because patients weren't willing to enter the trial. They were, I think, reacting more towards the negative news about that medication than the earlier positive news, and possibly with a good justification. Next slide. Otherwise, though, patients, once they have ARDS, the care is supportive. That begins with increasing oxygen support for patients who present with pneumonia, nasal cannula to high flow nasal cannula to BiPAP or non-invasive mechanical ventilation. We use prone positioning for these patients. I'll discuss that in a moment. But once they progress, we do use mechanical ventilation. About 50% of our patients so far and admitted to our ICU have required mechanical ventilation. More proning with that. Continuous hemodialysis and pressors if needed, which is not uncommon. And then deep sedation paralysis if necessary once they get more severe. And finally, we have an option for extracorporeal membrane oxygenation, which we've used here as well. Next slide. So I mentioned high flow nasal cannula oxygen. We're pretty liberal in trying to use this to help keep patients off the ventilator. These are data in regular ARDS or early ARDS, a randomized trial for patients going to either high flow oxygen, standard oxygen by base mask, or non-invasive mechanical ventilation. And as you see from these survival curves, patients who were randomized to the high flow oxygen arm were less likely to require mechanical ventilation and had better survival from standard ARDS. If the patient has COPD or obesity, we will go to non-invasive ventilation first. In COPD, because it's been shown to reduce mortality and COPD exacerbations, and in obesity for reasons I'll explain in a moment. Next slide. So once patients are intubated, the key principle is to try and ventilate them in such a way that does not further injure their lungs. That means not making our tidal volumes too high. You see a tidal volume pressure curve there in the middle. So you don't want to use tidal volumes that are too high, and you want to use enough positive end expiratory pressure to keep the alveoli from collapsing at the end of every breath. Next slide. So based on that principle, we know from previous large clinical trials that using tidal volumes on the lower side, like 6 milliliters per kilogram predicted body weight, lead to better survival than higher tidal volumes, like 12 milliliters per kilogram predicted body weight, as long as we keep the plateau pressures less than 30 centimeters of water. So in other words, we try not to over-distend the lung. And with that, we'll have lower mortality with mechanically ventilated patients. And that's been standard of care for some time now. Next slide. But as I mentioned, expiratory pressure to keep the alveoli collapsing. So if that on that middle curve, if you look at the bottom portion of it, you see a lower inflection point And so we try and keep the pressures at the end of expiration high enough that we don't get below that inflection point and the alveoli stay open. Next slide. So this is a meta-analysis of several trials looking at protocols with higher levels of positive and expiratory pressure, or PEEP, versus lower levels of PEEP. And you see there's a small but important survival advantage with higher levels of PEEP. And this is in patients with severe ARDS, like with bad COVID-19 pneumonia. Next slide. Not every patient responds well to positive expiratory pressure or recruitment maneuvers. These are two panels of CT scans. The top panel are CT scans of a patient who had ARDS and was put on a higher tidal volume briefly and then high levels of PEEP to try and recruit that collapsed lung that was there at the bases. And you see that there's very little recruitment of lung. At the lower panel was another patient who similarly had significant ARDS, predominant in the bases like we usually see. That recruitment maneuver and higher PEEP was actually quite successful in recruiting collapsed alveoli. So we work with the patients and work with ventilator pressures and measures of lung compliance with different settings to identify which patients benefit the most from higher PEEP and try and personalize it accordingly. Next slide. Now, of the patients admitted to UNC, our most common comorbidity is, in fact, obesity. And a number of studies have shown worse outcomes associated with obesity, and we can illustrate that with a case. Next slide. So here's a typical CT scan of a patient with COVID-19 pneumonia. I say typical because this isn't the most severe example, but certainly significant enough that the abnormalities are noticeable on CT scans. You see these multiple focal areas of consolidation. Typical of ARDS, a little bit more significant in the posterior segments of the lung. Well, this happened to be a patient who was 36 weeks pregnant. She wasn't obese, but a significantly gravid uterus mimics obesity in a way, at least truncal obesity. And so even though this wasn't the most severe CT scan we've had, her oxygen requirements are actually quite high and increasing. So we had to take her, or the obstetrician had to take her to OND and induce her. She started out on about 40 or 50% high flow oxygen. Ultimately had to go to C-section because it was her first pregnancy and she was progressing slowly. But the morning after her C-section, remember the morning of she required 50% FiO2 by high flow nasal oxygen. She was down to just 1 liter of nasal oxygen by the next morning and off altogether by the next afternoon. So that's just a case example of how, even with a mild to moderate lung injury, restriction of diaphragmatic movement by pregnancy or by obesity can greatly increase the oxygen requirement for patients because they have much less reserve. Next slide. So patients kind of learn from this that lungs can be recruited in some patients. I've shown you several examples of where the lung lesions can be worse in the posterior segment. So this is results from a clinical trial of proning for patients with severe pneumonia, and indicating that survival is higher in patients who are turned over onto their stomachs while they're on the mechanical ventilator, because you can improve oxygenation, you can improve lung function, and reduce ventilator-associated lung injury. Next slide. We translate that to, next slide. So we translate that to patients who are not intubated for COVID-19 just because of large number of patients, and we've learned we should do what we can do to keep them off the ventilator. And these are data from at least a case series of patients who weren't ventilated, but were prone while they were on various degrees of oxygen. And about 25% of patients will both tolerate it and respond well to it and reduce their oxygen needs and possibly reduce the need for mechanical ventilation and improve survival. And we're conducting a randomized controlled trial here of this procedure to see if indeed it improves patient outcomes. Next slide. I'm going to skip a couple next. This is just a quick slide to remind everyone that it's not just older patients who get COVID-19 pneumonia, that patients from adults from any age group can require hospitalization for COVID-19. And the mortality is not insignificant. So a lot of your friends who say, oh, I'm not worried, only old people get it and suffer from it, that is not the case. Next slide. These are outcomes from UNC Hospital for patients admitted with COVID-19. The mortality rate here reflected early May was only 20%. In fact, right now it's lower, running around 14 or 15%. So even though this condition is worrisome and a bit frightening, in fact, most patients, even admitted with pneumonia, wind up surviving hospitalization, and only those more severe patients have the worst outcomes. Next slide. Now, this is, I think, most important for primary care physicians. Just a reminder that patients who have had severe pneumonia, and especially ARDS, whether it be from COVID-19 or other causes, suffer significant physical dysfunction after hospitalization and significant cognitive dysfunction sometimes after hospitalization, particularly elder patients. They also have significant emotional problems, including depression and PTSD symptoms, as do their family members, because it's a very traumatic experience for them to go to as well. So be sensitive for these issues when one of your patients survives hospitalization and gets out of rehab, that some of these problems for them might be lasting for quite some time, and will be problems they have to try and compensate for. Last slide. Just a quick acknowledgement, particularly of the nurses in our hospital who have helped us achieve what I think are good outcomes for these patients, and all the other large team that works with it. I'll stop there.
Okay, my name is Nigel. I'll be taking over here and talk a little bit about the coagulopathy. Just a reminder for those of you who came in late to mute your phones or computers and the video as well. So next slide. This reminds me, this COVID, of the Indian parable of the 7 blind men, each having a piece of the elephant and trying to figure out what the elephant looks like and what kind of beast it is. And in fact, there might be African elephants and Indian elephants here. Shannon's already alluded to some of the differences with regular ARDS, if I can call it that, and I'll be emphasizing that as well. Next slide. So to summarize, first of all, a variety of thrombotic manifestations that have been described with COVID-19, and we're still trying to get our knowledge around exactly what the rates are, particularly for outpatients, and I'll come back to that later. But there is definitely a systemic coagulopathy in these patients, microvascular thrombosis, and then venous thromboembolism, which is a term used to encompass both pulmonary embolism and deep vein thrombosis, certainly seems to have a high rate in hospitalized patients. Ischemic stroke, and there's an arteriogram. You can see there that some of the small branch vessels are also included, not just large vessel stroke. Myocardial infarction, and then systemic arterial embolism. You can see a picture there on the bottom right. Then other Dermatologic manifestations like purpura and chilblains or pernio have been described. And then Dr. Flythe, I think, will talk about some of the systemic clotting that manifest as difficulty with extracorporeal circuits when you're trying to dialyze these patients, for example, as a manifestation of the coagulopathy. Next slide. So in these patients, most typically the prothrombin time is either normal or very mildly prolonged. The PTT is usually normal, although a subset of patients have been described to have lupus inhibitors, usually not with a full range of antiphospholipid antibodies. The D-dimer has attracted a lot of attention, and it's already been alluded to that this can be elevated and sometimes extremely high. It may have prognostic significance that I'll come back to. Fibrinogen levels are elevated usually, and they can sometimes be extremely high. Thrombocytopenia is not a major feature of COVID, though a lot of patients may be in the 100 to 150 range when they get hospitalized, but severe consumption of platelets and fibrinogen is not really what you see here. And this has led to the term of COVID coagulopathy to distinguish it from more typical consumptive DIC, where clotting factors and platelets are consumed on a widespread basis. So it seems to be somewhat of a distinct entity. Next slide. So these are some of the original data from China, from Wuhan. And although you can see rather dramatic changes in green in the non-survivors, the vast majority of patients, of course, are going to be survivors. And you can see the prothrombin time on the left and the APTT on the right with the upper limit of normal is generally not very prolonged, or at least minimally in prothrombin time. However, there's a subset of patients who may start going down the wrong pathway where the prothrombin time starts to prolong. Next slide. And this can be associated with an extreme elevation of D-dimers. Now, the D-dimers on admission, if you look, the scale on the x-axis is the days following admission, might not be very distinguishable at that point, but they are different from the non-survivors, at least in this case series. The fibrin or fibrinogen degradation products, of which D-dimer is a subset, these are really telling you the same thing, that there is turnover and consumption of fibrinogen in some of these people who do badly, and they may go on to develop what is a more typical DIC picture, but this is really quite uncommon. Next slide. And lastly, you can see the fibrinogen is usually elevated. It can plummet as a terminal event in some non-survivors. This would be more typical of consumptive DIC, but for the most part, clotting factors levels, and this is shown with the antithrombin level on the right, which in a typical DIC can be very low. These are relatively well preserved and may even be elevated like the fibrinogen. Next slide. So I mentioned the D-dimer as a prognostic marker, and there's still some controversy about, but for the most part, I think studies that are even now beginning to come out are suggesting that the D-dimer, as you recall, is a measure of formation in the vasculature of cross-linked fibrin, which is then broken down by the fibrinolytic system. So there is fibrin turnover, but it's compensated by fibrinogen levels. And you can see here that, again, this is from some of the original Chinese data showing that D-dimer levels that are elevated had an odds ratio of almost 20-fold for in-hospital death. Now, there's some variety in the data that have come out subsequently, but I think for the most part, this is holding up along with CRP and some other biomarkers as interleukin-6 as adverse prognostic markers. Next slide. So this term COVID coagulopathy has been coined, and this, as I mentioned, appears to be somewhat distinct from classic form of consumptive disseminated intravascular coagulation. It is associated with increased risk of death, And the thrombotic events increase substantially with disease severity. And there's an increasing tendency now to start looking at patients as those patients who are hospitalized but not in the ICU versus those that are in the ICU. And undoubtedly, there's a step in terms of the intensity, the coagulopathy as you proceed through those levels. So although again there's some controversy about the thromboembolic complication rate, it seems to be significantly greater than what you might expect in other similar sick ICU patients, ARDS patients, and there is a greater risk of breakthrough even with prophylactic anticoagulation, which has led to the concept of, do we need to intensify prophylaxis on inpatients? And I'll come back to that. Interesting, pulmonary embolism detection seems to dominate over deep vein thrombosis, and this may reflect some of the pathophysiology, which I'll also come back to. There may be a couple of processes going on in the lung, of which classic pulmonary embolism is just one. Bleeding is not that common, but it nonetheless has to be reckoned in terms of the dose of anticoagulation that are used in these very sick patients who may have renal failure and other risk factors for bleeding. And frequently the venous thrombotic events are not clinically suspected, or a patient may be doing well and then suddenly deteriorates from a pulmonary standpoint and is found to have a large pulmonary embolism. The D-dimer I've already dealt with, so I won't dwell on that. Next slide. So autopsy data was initially slow to accumulate, and it still is coming out. And we've gone from single or double cases to 10 or 12 cases. I like this study because these were consecutive COVID deaths in Germany. And in the setting of a pandemic, I guess this was mandated by law in that part of the country. So very informative. These are a typical demographic of older patients with usual comorbidities. And at autopsy, they had the diffuse alveolar damage, which is typical of ARDS that Shannon talked about, with leakage into the alveolar space. But in addition, about 60% of patients had a deep vein thrombosis that was not diagnosed pre-mortem in any of these patients. And massive pulmonary embolism was thought to be the direct cause of death in a third of these patients. And so at further microscopic level, microthrombi, and this may be the second process that is distinct from pulmonary embolism, were regularly found within small lung arteries, occasionally within the prostate, but not in other organs. So again, small numbers of patients, but similar data have come out with 10 or 12 autopsies from other parts of the world at this point. Next slide. So here you see at autopsy on the left-hand side, there are arrows pointing to small vessel thrombi, and on the right-hand side, below the ability to recognize either visually at autopsy or probably by conventional CT angiography, you can see this microvasculopathy with the green arrows pointing to pure fibrin thrombi in many microvessels, and the yellow arrows pointing to microthrombi consisting of platelets and mononuclear cells. Next slide. So this begs the question, what is going on here in terms of this particular entity? Is this classic ARDS and classic lung injury, or is there something unique about it? Certainly coagulation plays a part in ARDS generally, but this does seems to be emerging as a somewhat if not unique, exaggerated form of viral-induced lung injury. Next slide. So I'll go into a little bit of pathophysiology here, and the term endotheliopathy, as you will surmise, really suggests that this is a disease of the endothelial lining of the vasculature. And what might be going on here? Well, a term has been coined in my field, that of immunothrombosis, in the last few years, where in response to infection, we've evolved over the millennia to react in a very acute way with an innate immune response. Usually neutrophils and monocytes are responsible for this. But it also may be triggered by a term you may have heard in association with the COVID, which is a cytokine storm. This is where our ability to send up danger signals gets out of control and is exacerbating the whole process. And this, frequently one of the targets of injury here can be the endothelial cells. Next slide. So to take you back to Pathology 101, and basically starting at the top left, you can see pathogen-associated molecular patterns. These are things like endotoxin. They can be RNA and DNA from viruses that monocytes recognize and send up the alarm signal so that tissue factor procoagulant is made. Neutrophils also react and start to do their thing, which means kicking out a lot of chromatin material, DNA, proteases to fight back, try to wall off the infection, and so on. Essentially a out of control reaction to this virus, which in the bottom right can lead to endothelial damage as these cells try to wall off what they see as an invader. Next slide. I won't dwell on this, but basically there's at least 5 different mechanisms shown here that give the endothelial cells its role as the Teflon of the blood vessel. We go to extreme lengths to prevent adhesion of platelets, neutrophils, and the formation of blood clots on the vasculature. And these are some of them that are shown here: antithrombin, participating prostacyclin, nitric oxide, protein C mechanism, etc. So the endothelial cell is not just a bland lining layer. It is very active in terms of fulfilling this role of preventing clotting. Next slide. So in addition to immunothrombosis, which I've just dealt with, the other thing that has been proposed here, and I'm not sure whether it's right or not, is whether this particular virus can directly infect the endothelium. Certainly many viruses can, and they can perturb the function or even lead to apoptosis or cell death of the endothelial monolayer. Next slide. This was raised, this is a paper, I think a German paper showing, and I won't go through the various panels, but essentially what they're showing is the inclusion bodies, the viral inclusion bodies in the endothelium of various organs. And this is still controversial because the ACE2 receptor for the virus is not probably expressed on endothelial cells. And so the question is, can it be upregulated? Is there another receptor? Is there another way that it can get in? And the truth is we don't know at this point, but there may be direct endothelial infection by this virus. And this is a space that, to watch if you like, but it certainly would, in theory at least, lead to significant perturbation of endothelial function. Next slide. So the last thing, and I won't dwell too much on it, is that's been hypothesized, is that hypoxia at the microvascular level can lead to coagulation activation. And this is well known, and this has been studied in cancer and other hypoxic conditions within the tumor cells I was talking about, but essentially this whole pathway. Next slide, very briefly. We'll show you that here at the top in the red, the HIF1 pathway, which can be turned on by hypoxia, can upregulate tissue factor, the procoagulant. On the bottom, it can upregulate a anti-fibrinolytic protein known as plasminogen activator inhibitor. So at the same time that we're turning over fibrin through the plasmin mechanism, there's upregulation of PI1, and these levels are high in these patients. And then in the green pathway, you can see the HIF pathway 1 and 2 can also downregulate some of the protective anticoagulants, such as protein S and tissue factor pathway inhibitors. So the net effect is to tip the balance towards more coagulation and thrombosis. Next slide. So to summarize here, we probably have essentially two things going on. One is this localized pulmonary thrombotic microangiopathy. Somebody is termed as microclots, but it's essentially immunothrombosis. It may be not, again, unique to COVID, but it may certainly be exaggerated. And this can be sometimes difficult to distinguish from what clearly also is going on, which is pulmonary emboli, particularly if it involves, subsegmental vessels and so on. But this may also extend to the very small vasculature and account for some of the lack of compliance with ventilation and the very high D dimers and some of the other features here. So I think that the field is sort of swinging towards thinking about this as two separate processes, one that we recognize as venous thromboembolism or arterial thromboembolism, and the other is this pulmonary microangiopathy. Next slide. So I kind of like this suggested slide here, what may be going on. That the lung is really where the virus enters, or essentially through the nasal cavity or nasopharynx, and then spreads down essentially to the lung, that this becomes the epicenter of a progressive coagulopathy. And this group suggested that there might be these stages here, where in the earlier stage, this might be a pre-hospitalized or early hospitalized patient who has some D-dimer elevation that's modest, platelet count may be normal, prothrombin time may be normal. Stage 2 disease essentially is where the D-dimer is starting to elevate, there's a mild decrease in the platelet count, and maybe a mild prolongation of the prothrombin time. And these patients may be hitting the ICU at this point. And then essentially you run into a very exaggerated form of that with platelet counts starting to drop and the prothrombin time starting to elevate. And these are suggested to be patients where essentially we're losing control of their disease at this point. We've been having some trouble advancing. Here we go. So in terms of anticoagulation, and again, you all being a primary care audience, this was originally given for the inpatient and the hospital side, but I think that anticoagulation is important to consider. So on the outpatient side, you can see the top row, it says consider standard VTE prophylaxis. And what the superscript is referring to is there may be higher risk patients on the outpatient side who merit VTE prophylaxis, but we truly do not know who they are for sure beyond a few exceptions. There are patients with high-risk cancers, for example. We know what the rate of thrombosis is in those patients. There are other patients, perhaps elderly or history of thrombosis, but we don't really have a good grasp on the epidemiology at all on the outpatient side yet. And anticoagulation is not without its own risks. On the inpatient side, I think it's clear that everybody needs at least therapeutic dose anticoagulation. I'm sorry, I meant to say prophylactic dose anticoagulation. Everybody, I think, with COVID who gets admitted is getting at least prophylactic dose anticoagulation, and that might be 40 milligrams a day of Lovenox, for example. The controversy arises whether to escalate that dose to like double dose prophylaxis, or even in some centers to start moving towards therapeutic dose in the absence of a standard indication such as thrombosis, proven thrombosis. And these are sort of open to discussion. Next slide. I'm just coming to an end here. So I won't go through this, but this is available through the UNC intranet, but essentially this is an algorithm we've designed. It's very similar to what's used throughout the country, but essentially group C on the right-hand side would be your patients who have a lower intensity disease. They're going to get prophylactic anticoagulation, attention paid to their body mass index and GFR. If they start to escalate, and here's where particularly a rapidly rising D-dimer, at our center we escalate to an intermediate dose anticoagulation, which is about half of the full therapeutic dose of enoxaparin, 0.5 per kilogram Q12 hours. On the bottom right, I wish I could give you more details on how to best to treat patients following hospital discharge, but let me just say we're doing this selectively in patients at the moment. We had started more as a blanket recommendation and pulled back on that a little bit. Next slide. The last slide, I think, is essentially really what we need are the randomized controlled trials. And I will tell you that NIH is gearing up for massive anticoagulation studies. Some are being done around the world. We may know about this. We need to know more about the risk of thrombosis in outpatients, and we need to know more about the pathophysiology so we can really practice evidence-based medicine. I think next slide, maybe one more. Okay, that's it. Thank you very much. Sorry I went over.
Thank you. We can go to Dr. Flythe now.
That's my backup slide. I don't need that one.
So I'm going to talk about kidney-related complications of SARS-CoV-2, and I will try to do so quickly since we are nearing our time. Next slide. First, a case to set the stage. This is a 67-year-old Hispanic man who had a past medical history of non-insulin dependent diabetes and hypertension. He was admitted to the UNC MICU in May with a COVID-positive pneumonia. He was intubated. He required intermittent vasopressor support, and he was also being treated with Piptazo for a possible gallbladder infection. When he was admitted to the hospital, he had normal creatinine, so admitted on April 28th with normal creatinine, and it remained nearly normal for about a week. And about a week into his hospitalization, his creatinine started to bump, and nephrology was ultimately consulted on the 8th when his creatinine reached 2.6. And so the question is this SARS-CoV-2 related AKI, and how do we know? So we'll return to this case later on. Next slide. Next slide. So early on in the course of the SARS-CoV-2 epidemic, acute kidney injury was not really appreciated as a major feature of the disease. Early reports from China and Italy documented an acute kidney injury or AKI rate of anywhere from 0.5 to 29%, with most of the reports being on the lower end of that range. In the US, the early reports came from Seattle, and an ICU there, in a small number of patients, reported a rate of AKI of about 19%. But as the pandemic moved east, reports of AKI grew, and this is data from the Mount Sinai Hospital system, where they reported an overall acute kidney injury rate of 46% among patients with SARS-CoV-2, and that rate actually rose to 68% when you restricted it to patients who were intensive care unit patients. Next slide. These are data from another large hospital system and is probably the most recent data. So 13 hospitals in the New York Northwell Health System, they reported an overall acute kidney injury rate among patients admitted to these hospitals at 37%. And then using data from the electronic health record, they identified older age, Black race, several comorbid conditions, and then not surprisingly, the need for ventilation and vasopressors as risk factors for acute kidney injury. And in this particular cohort, the death rate was about 35%. So next slide. One of the most striking aspects of this study was the observed temporal association between respiratory failure and acute kidney injury. Specifically, what they found was that 90% of patients on ventilators developed AKI compared to just 22% of those who did not require mechanical ventilation. And of those that developed AKI that actually required dialysis, 23%, it was 23% of mechanically ventilated patients compared to just 0.2% of those who didn't require mechanical ventilation. And interestingly, over half of these patients had onset of their acute kidney injury within 24 hours of intubation, again suggesting some kind of lung-kidney connection in the case of this disease. Next slide. So what about outcomes? In general, having acute kidney injury with SARS-CoV-2 portends a bad outcome. In Wuhan, one study reported that 11.2% mortality rate among patients with AKI compared to a mortality rate of just 1.2% of those without. In New York, 45% mortality rate among those with AKI compared to 7% without. And in some adjusted analyses, they actually found that the odds of death were close to 20 times higher among patients with AKI compared to those who did not have it. Next slide. So how does our data at UNC compare? So this is data from mid-May and includes 57 patients that were admitted to our medical intensive care unit. This number is well into the low 100s now. On average, these patients were 57 years old. Over 60% were male, consistent with national data. About 37% were of Black race, although we had a fair amount of missing race data. And then over a third were Hispanic ethnicity. Over a third had diabetes, close to 60% had hypertension, and about 14% of the cohort had chronic kidney disease when they were admitted. And so what we observed was about a 60% rate of acute kidney injury. Again, these are among patients admitted to the ICU. And about 20% of the patients required dialysis. Of those, 8 were put on CRRT to start with, and 4 were on hemodialysis as their initial modality for treatment of their AKI. And in general, most of these patients were initiated on renal replacement therapy within 48 hours of their intubation. And again, among these 57 patients, the in-hospital mortality rate was about 40%, with an unadjusted odds of death being about 11 times higher among those who had concurrent acute kidney injury as opposed to those who did not. Next slide. A clinical picture of SARS-CoV-2 related AKI is starting to emerge with features that are typical of any AKI, such as a rise in creatinine, decline in urine output, and then again, as we discussed, this close temporal relationship between AKI and respiratory failure. On urinalysis, about 50% of patients have hematuria and or proteinuria. And on microscopy, many patients have white blood cells, red blood cells. And then interestingly, in the cohort of patients from the Northwell Health System, they actually found a relatively high median specific gravity and low urine sodium. So these constellations of findings can be seen in a number of different kidney injuries, including pre-renal states, glomerular nephritis, and forms of ATN. Next slide. What we know about kidney pathology comes from autopsy studies, similar to those that Dr. Key mentioned. These are data from 26 Wuhan autopsies, where they observed several different types of disease in the kidneys. So starting with panel A, it shows you vacuolization in the proximal tubules with necrotic debris and tubular lumens. We see this in tubular injuries, such as with ATN. In panel B, infiltration of inflammatory cells to the point where there was actually one white blood cell cast, which can be seen at the black triangle. In panel C, there's segmental fibrin thrombi in the glomeruli, suggesting, again, a role for coagulopathy in the kidney injury. In D, they actually noted virus-like particles with spikes in the proximal tubular epithelial cytoplasm, suggesting that there could be direct viral invasion of some of the kidney cells. Similarly, in panel E, these similar features were seen in podocytes. But again, of these relatively diverse pathology findings, tubular injury as seen in panel A is the most common. Next slide. Now, people have questioned whether or not there actually is viral invasion of the kidneys. That study was followed up by a letter to the editor that suggested that rather than being viral particles, that those small things that they were observing were actually cellular vesicles. And so the only way to confirm this is to note the presence of viral RNA in the kidney cells. Next slide. And soon after this, there was a publication in the New England Journal. This is the same 22 autopsies that Dr. Key mentioned. And what they found in this study was that there was enrichment of multiple kidney cell types with RNA for the ACE2 and other genes considered to facilitate SARS-CoV-2 infection. And what they found was that there was actual detectable SARS-CoV-2 viral load in all kidney compartments, suggesting that there likely is direct viral invasion of important kidney cells. Next slide. SARS-CoV-2 accesses cells via the ACE2 receptor. The receptor is ubiquitous, present on many organs, including the kidney, where it can be found in the glomeruli and in the proximate tubules. Next slide. After entering the cell via endocytosis, SARS-CoV-2 activates the RAS system, which in turn activates complement and coagulation pathways that have numerous downstream effects that can lead to the hypercoagulopathy that we just discussed, microangiopathy, as well as the cytokine storm activity and its downstream consequences of clotting, endothelial complications, and then specific to the kidney, both tubular and glomerular damage. And finally, as we mentioned on previous slides, there's this concern for direct viral invasion, which may contribute to rhabdomyolysis and also to direct tubular and glomerular damage. And then all of these structural injuries are compounded by the concomitant hypoxia and hypotension that are occurring in the setting of multi-organ damage. Next slide. Thus, acute kidney injury and COVID-19 can be attributed to numerous factors, including hypovolemia. We're often under-resuscitating these patients because we're so concerned about volume overload given the severe respiratory complications in ARDS that we're seeing and we heard about from Dr. Carson. Oftentimes, these patients can be over-diuresed and then often exposing them to high levels of PEEP, which can lead to decreased venous return and hypovolemia to the kidney. We also see this idea of ATN, which can occur through cytokine storms, can occur independent of that with just severe hypoxic respiratory failure, and also in the setting of organ crosstalk. We also talked about this glomerular and vascular involvement from microthrombi, as well as endothelial and vascular damage. And then many of these patients are in a low perfusion state or have venous congestion, whether it's from being in cardiogenic shock or again, having some right ventricular dysfunction due to high levels of PEEP and associated venous congestion. And then finally, this idea of direct viral infection and associated complications from that. But I think importantly, multiple of these mechanisms are likely at play in any single patient. So next slide. And then that brings us to the question of, are RAS inhibitors helpful or harmful? Early on in the pandemic, there was a concern that RAS inhibitors might actually worsen COVID-19, and many people were suggesting that people stop ACEs and ARBs in the setting of COVID-19. And ultimately, because of the role of the ACE2 receptor, but there's actually a counter argument to that, which could be that ACEs and ARBs may be helpful in these patients, particularly ARBs, as they decrease the activity of angiotensin II. So there have been a number of observational studies that have looked at whether outcomes differ among patients on ACEs and ARBs versus those who are not. This is recent data from a meta-analysis that includes 16 studies and close to 25,000 patients. And what they found was that patients that were on ACEs and ARBs and remained on those medications actually had better outcomes than those who were taken off these medications. But ultimately, I think the jury is still out on this. These are, again, observational studies, and I don't think that we know definitively, but at this point, we are not stopping ACEs and ARBs in the setting of COVID-19. Next slide. Next slide. In terms of management, it's important to explore multiple mechanisms and potential causes. You know, when we see these patients, we are always trying to assess their volume status, and I'm sorry, and then we're looking at a number of other things, including respiratory failure, timing, and severity. And then we consider a number of other contributing causes. Just because the patient has COVID-19 certainly does not mean that their kidney injury is coming from the COVID-19. So we look at episodes of hypotension, medications that they're on, whether they've been exposed to nephrotoxins, contrast, rhabdo. And then we also ask the question, is there a new and unrelated disease process? Urine sediment often drives many of our decisions when we are doing nephrology consults. Currently in the UNC system, we are not doing sediment evaluation unless we do so in a sealed centrifuge, which we do have the ability to do here at UNC. So next slide. So in terms of management, as we talk about, we explore multiple mechanisms as we would with most AKIs in the setting of critical illness. We look at volume status and then take the usual kidney protective measures of stopping nephrotoxic medications and dosing medications appropriately to GFR. In terms of renal replacement therapy in the setting of COVID-19, we really don't have any new insights in terms of timing of initiation. We do see that volume control is the most common indication for starting patients on dialysis. Next slide. Let's return to our case. So I've added a little bit more to the time course here. And what you could see was this patient was intubated right when he was admitted on April 28th and had about a week where he had intermittent periods of hypotension. And then there was a question of a potential gallbladder infection. So he was started on Pip/Tazo on May 4th. And then ultimately, the creatinine didn't start to rise until about 7 days into his hospitalization. And so when we saw this patient, we were certainly worried about COVID-19 related AKI, but we also felt like the role of the antibiotic might be more temporally associated with it. And so the initial recommendation was to stop the Pip/Tazo. As you can see, a couple days after that, his creatinine began to trend down. Advance. And so what we concluded about this patient was that the predominant underlying pathology was likely acute interstitial nephritis, but he likely also had some contribution from acute tubular necrosis in the setting of the hypotension, and also possibly related to the SARS-CoV-2. And in his particular case, his ultrasound showed slightly small kidneys, so he likely had some underlying disease as well. So again, multiple processes, but in this case, there was an intervention that we could make that actually improved his course. Next slide. So we talked a little bit about remdesivir, and so as Dr. Carson mentioned, remdesivir is we are not allowed to use it in patients who have GFRs of less than 30. So when the FDA issued their emergency use authorization in May, they said the pharmacokinetics of remdesivir have not been evaluated in patients with renal impairment. Remdesivir is not recommended in adults with GFRs less than 30 unless the potential benefits outweigh the risk. And so remdesivir is about 75% renally eliminated, and there are a couple of potential mechanisms of its toxicity. One is direct mitochondrial toxicity in the tubules that has been demonstrated in animal studies, but at relatively high doses that are given for long durations. So I think in general, this is probably a lower risk. And then the second potential mechanism of toxicity relates to its carrier, which is this sulfabutylene beta-cyclodextrin, which is the same carrier that is actually used in voriconazole. It's a solubility enhancer that also has some nephrotoxic effects. So because of these reasons, the FDA recommends caution for patients who have GFRs less than 30. In general, the nephrology community, I think, thinks that these are probably overcautious, but we are bound by them. And so with the exception of really rare exceptions, we cannot give the drug to patients with GFRs less than 30. Next slide. So SARS-CoV-2 has brought a unique set of dialysis challenges. As Dr. Key said, we experience a lot of circuit thrombosis when patients are on either regular hemodialysis or on CRRT. That's associated with blood loss as they lose these systems and often related to inadequate dialysis treatment. It also increases the risk of staff exposure because they're having to go in and out of the rooms more often to deal with the alarming machines. So we are using much higher doses of anticoagulation. Many of these patients are already on systemic anticoagulation. If they're not, we often require systemic anticoagulation in order to successfully dialyze them. And in many cases, we're running concurrent systemic and circuit anticoagulation and certainly targeting higher PTTs than we typically do in renal replacement therapy. Next slide. And as many of you have seen and has been reported by a number of news outlets, one of the issues that has come up is the need for dialysis machines. This is not an issue we faced at UNC. Our population numbers have been relatively manageable. Next slide. But certainly when you are dialyzing in a pandemic, you're always, like with all resources, asked to do more with less. And so what we're seeing is we are seeing more patients with AKI, more needs for renal replacement therapy. And then we have less dialysis personnel, often due to infections. And then we have less equipment, simply because we have had more patients, but we've also had a lot of supply chain problems across the country. Next slide. At UNC, we took a number of steps to try to avoid this. We cross-trained ICU nurses. We bought additional machines. We're keeping more supplies on site than we normally would. And then we have a number of contingency plans that if we were to run out of machines, that we could do more machine sharing and also use more peritoneal dialysis. This has had to be done in many of the New York hospitals. But again, we've not gotten to this point and hope not to here in the UNC system. Next slide. So in conclusion, acute kidney injury and SARS-CoV-2 is very common. And AKI, particularly severe AKI, really portends a poor prognosis in these patients. And as we talked about, the etiology is likely multifactorial related to the cytokine storm, ischemic damage, and endothelial damage, as well as thrombosis and potentially direct infection. But when we're seeing these patients again, and for teams taking care of these patients, we emphasize it's important to fully consider the full differential diagnosis as these patients still get AKI from other causes, as we saw in the case example. All right, that's the end of mine.
Thank you so much. We really appreciate all of our speakers today and the participants. We do want to let everyone know that participated today that the recording will be posted by next week on the UNC Health Physician Resources page. And then also for those that participated today, you will automatically receive a WebEx invitation from us once our next CME date is secure for our COVID topic. And we appreciate your participation today. Let me see if there are any questions. I don't see any that have come through. If anyone else has a question, if you could go ahead and submit it through the chat. I don't see any. So thank you everyone for your participation. Bye-bye.